All right, so it is May 20th, and we are going to start today continuing the lesson from yesterday. So we're going to flip-flop the class a little bit. We're going to finish off the Kines lecture and then go into Therex. I wanted to give you guys a heads up because the schedule is posted. It takes about 2 hours to process through Blackboard because that's the way Blackboard works. I posted the schedule, which is a combined schedule for Kines and Therex, so that it kind of makes sense as we're going through it. It will make sense when you see the schedule. Don't worry about that. On Tuesday, which is our first full, long day for Therex. So not Monday. Monday, you have me for Kines again, late in the afternoon. But on Tuesday, we're going to not only lecture on Therex, but we're also going to do foundational Therex. So we're going to actually run through some basic kind of building block exercises that are going to be kind of the staples that we use in PT to help start building that toolbox for you guys, so that when you're ready, once you guys go out in clinic, you have a toolbox that you can keep building on. I talked to one of you guys yesterday, and I want to make this suggestion. I really, really recommend all of you get a 1-inch binder or something like that, and put on the cover of it saying, "This is my clinical binder," and put important things in there that are going to be related to your clinics. I'm going to give you stuff, and I will give you some, like the Therex we're going to do on Tuesday. There's going to be some stuff on pharmacology I'm going to give you that I will say, this would be really good to put in your clinical binder, so that when you're at clinic and you need a quick reference, you can go back to that binder and look at it, versus having to dig through maybe all your other binders to find stuff. One of the other things I highly recommend you putting in there is there were 2 things that Dr. Vreskin gave you. One of those being that list of the med terminology with the abbreviations. That would be a really good thing. And then also she has that, I think she made it in orange. I don't know what color sheet she made it in your growth and development, that has the stages of development that talk about, when ATNR integrates, when STNR integrates. Put that in there as well, just in case you encounter a kid. Because although some of you may be going, once you guys pick your placements on Monday, to an adult outpatient clinic, that doesn't mean you're not going to encounter a kid. I've had plenty of kids come into an outpatient clinic that we've seen, and the parents will bring them in, and we'll take them as patients, even though we may not be specialized in pediatrics. Somebody in the clinic has worked with kids before. Usually that ended up being me, because I was the one that worked with kids, but that happens. So keeping a nice binder together of that stuff does help. Now, when I went through my clinicals way back when, I actually took, and I joked about it, I used to call it my older person cart. You ever saw older people around here that go to the grocery store and they have those rolling carts that they pull behind them with all their groceries in? I bought one of those and put all of my books in it. And I took that with me every single day to clinic. And I had it in the corner because on my break, I was actually looking stuff up. That is going to be one of the key things for you guys when you're on your clinic, the first clinical, second clinical, and third clinical. As a clinician myself, I didn't care if you knew everything. That was not what I expected. I didn't expect you to know, how to manage all of the lines in an ICU. What I expected was, if I asked you something that you didn't know, that you went and you looked it up then for me. Maybe today we were working on somebody with a total hip replacement, and you forgot the total hip precautions for that hip replacement. I expected you to come back to me by tomorrow and say, hey, you know what, you're right. I didn't remember that, but then I remembered that Dr. Sokel taught us about it, and these were the precautions. I looked up them last night so that I don't make that mistake again. That's what I was looking for. That is starting to become an entry-level clinician, knowing that you're going to make mistakes. You're going to not know everything, but the fact that you will go and look up the everything that you're missing is important. One other thing I want to stress, don't make any plans during your clinicals. I don't know. So Riley, good question. So Riley asked, I'm going to be on the East Coast. What books would be the most important to bring? So the two that if I was carrying 2 books with me that I could take with me, Did you guys get your books today? I think you got most of your books today, right? I would carry Big Red and Little Green. So Big Red being the physical rehab book, and then Little Green being the Therex book. Those would be the two that I would definitely take with me. If you can take Patho with you, it wouldn't hurt. The it was Pathology for the Physical Therapist Assistant book from Dr. Sokel's class last semester. But Big Red and Little Green would be the two ones I would take with me for sure. The kinesiology book's great, but the nice thing about, I don't know if you guys saw this, but if you have that kinesiology book, you can register for the Evolve site and you can get a digital version of the kinesiology book while you're in school. So you could always access that online if you needed that one. But the rehab book, you can do the same thing, and the Therex book, you can do the same thing. But I think those are two of the foundational books I would always have with me. And then once we get to like your final clinical, so when you guys are going out in your third clinicals, by then we should have your Score Builders book, which is your test prep book. And that would be another one I would have with me, like on my third clinical. Does that help? Awesome. But yeah, so those are just a couple suggestions. The other suggestion I'm going to make to all of you, because I made this mistake on my first clinical, and I want to make sure you guys are prepared. Have a change of clothes in your car, meaning a change that you can change into and still work into. So if your clinic requires you to wear scrubs, have a spare set of scrubs in your car. If your clinic requires you to wear a polo and khakis like I am, have a polo and khakis in your car, because you never know when somebody is going to have a Technicolor yawn. Does everyone know what a Technicolor yawn is? It's one of my favorite terms, right? Technicolor yawn is a vomit or a code brown. Yeah, throw up, exactly, right? And code brown can be really impressive in the hospital. I once saw a guy hit the wall like 5 feet away. So that's when they poop themselves. So I always had a set of clothes and even a set of shoes. Yeah, so usually if you're at clinic and you're a clinic that's polo and khakis, usually the Pima Polo is the most acceptable because that at least identifies you as a student, right? That's an easy identification that you're going to be different than everyone else. One of the things I liked in my clinics is I always made sure that all of my clinicians looked the same. Usually what I did was my PTs were one color polo, my PTAs were another color polo, and then my staff were a different color polo. So it was easy to tell everyone apart. The PTs were dark blue, the PTAs were light blue, and the staff were black. It made sense that then the staff knew that they couldn't really ask PT questions of the staff, right? The patients knew that. So it just helps that if your clinic allows you to wear regular polos are acceptable as well. I don't think Dr. Reskin forces you to wear your polo all the time because you only have 2 of them and you're gonna be working 5 days a week, right? So unless you're one of those people that wash your polo every single day, which is possible. I mean, and again, once you guys get your clinical placement, just to let you know, if you need scrubs, if they require you to have scrubs, Pima will provide you with a set of scrubs. So don't freak out about that. We'll get there when we get there about that. Does that make sense? I just wanted to cover those couple things before we get into this because I thought of those last night after I got off with you guys and after Dr. Reskin and Dr. O'Neill talked through. So, all right, so we're going to transition. Any other questions about that before we go back into kines? Anything about the clinicals that you guys thought of overnight? I try to answer them. I can't answer all the questions. All right, no questions. We're going to move. So the last thing we talked about in kinesiology last night, and again, this is just a review of intro to kines, was talking about the labrums at the hip and the shoulder. That was kind of where we finished off. And we were talking about the articular system, meaning the joint system, and arthrokinematics, meaning the actual movement of the joints and measuring that movement of the joints, right? So here's kind of a picture of a bursa. The bursa's job, like I said before, is more of a cushioning surface. And it's a cushioning typically for tendons, not for bones. Cushioning for bones usually is that fibrocartilage, like your menisci in your knee and your discs, your anus fibrosus and nucleus pulposus of your spine. The bursa kind of lifts the tendon off the bone And really what it tries to do is keep the tendons and the ligaments from sticking down to everything. Because, like, say your patella tendon, for an example, where there's a suprapatellar bursa and infrapatellar bursa and all that, if that tendon kind of binds down, you're not going to have a nice fluid motion of the knee for extension and flexion. So that bursa gives a little bit of a distance and cushioning to that tendon. Oh, the planes and axis CCCs. You remember all these fun things from way back in anatomy, right? So I get a question often about this. Why is this important to understand? Well, the reason why the planes are important to understand is when we get into manual muscle testing this semester with Kines, you will find that if you manual muscle test something, say, in the sagittal plane with gravity, the way to remove gravity is to move it into the coronal plane or the frontal plane. So we'll talk about that type of a thing where, you know, if you're testing the biceps and the biceps are doing a curl, right, that's against gravity, sidelining and moving that into more of a frontal plane motion then actually takes and removes gravity. And so you may hear me say that, right? The sagittal is the one that kind of divides us this way. Coronal comes down through the head. That's the way I always remembered it, right? And then transverse cuts us somewhere through the middle. And usually for transverse plane, the only time we really talk about that is when we're talking about MRIs or CTs, because a lot of times they'll take transverse cuts and we'll be able to see specific parts of the spine or maybe the knee and the meniscus to look at it to see if there's damage. Degrees of freedom. This covered a little bit when we were talking about the different types of joints, right? The uniaxial, biaxial, and triaxial. If a joint is uniaxial, and this gets people for some reason on the boards, I don't know why. If a joint is uniaxial, it has 1 degree of freedom. It moves 1 motion. If it's biaxial, it has 2 degrees. If it's triaxial, it has 3. If it has more than 3 degrees of freedom, they consider them multiaxial. So unfortunately, once you get to multiaxial, like the hip and the shoulder, it really doesn't specifically say how many different motions you have. You just have to know them all. But if you get a question on the boards that might ask about this, saying something like the, I don't know, say the knee is a uniaxial joint, how many degrees of freedom is it? Or whatever joint they're talking about, or the elbow. Say the elbow provides elbow flexion and extension as a uniaxial degree of freedom. How many motions does it provide? Well, it's 1 degree of freedom, so it's primarily that 1 set of motions. All right, so here is where we're going to start getting into the review stuff that almost none of you guys usually recall, and that is osteokinematics versus arthrokinematics. Any of you willing to admit that this is stuff you really didn't like from Intro to Kines? This is where we start talking about maybe roll, spin, and glide and all that fun stuff. Yeah, right? This is not, and I'm going to hit this again because there were a lot of board questions on this. There are a lot of board questions on this because it's a really easy thing to write questions on. Like, you got to understand, when we're writing 5,000 questions for the boards, sometimes you have to pick stuff that's easy to write for. So osteokinematic is bone on bone movement. Arthrokinematic is joint motion, right? And remember, when we talk about joints, we're talking about joints of the body. We're not talking about stuff that's now legal in Las Vegas. We're talking about joints in the body, right? I don't know if there'd be arthrokinematic motion to that. I don't know. I don't know anything about that. So osteokinematic is that bone-on-bone movement. It's the gross movement of the shafts of the bone rather than the movement at the actual joint surface itself. So when we measure goniometry, and we're going to do that this semester, taking joint measurements, we are measuring the osteokinematic motion, the movement of, right, the ulna and the radius on the humerus, right? So that we know how funny the arm is. All right, I got somebody good. Goniometry is the measurement of those angles, and particularly the measurement of the angles created by those joints. Remember that within goniometry, I talked about this way back in math and physics, those of you that had me. The most any joint in the body has in range of motion is 180 degrees. That's at the shoulder, right? Shoulder should have a full 180 into flexion and a full 180 into abduction. Anything other than that is less than 180. The only reason I say that is when we get the goniometers, and I'll get one out then here in a few minutes. I forget where I put my goniometer at right now. I don't know where I set it. I brought it out and I don't know where I put it down. The goniometer has a full 360-degree measurement. So I've seen it before where somebody will measure wrist ulnar deviation, and they'll say, well, the patient's got 235 degrees of ulnar deviation. I'd be like, wow, that's impressive. That means that wrist went all the way around and came back, right? Don't get tricked by looking at that. You're looking at the wrong side of the goniometer. You're exactly right, Riley. Right, and that's going to happen. And what we're going to do is when that happens, when we're practicing, we're all going to get a good laugh out of it. Why? Because humor helps us remember things, right? Think about when you guys were remembering the cranial nerves and all that. You didn't necessarily remember the clean mnemonics. It was the more humorous or dirty mnemonics that you remembered. Humor helps you remember things. And I always joke that I've got 45,000 song lyrics in my head, but I can't remember where I put my glasses when I take them off, right? Because certain things trigger storage, right? I can remember songs in Swedish, but for whatever reason, I forget to turn the dishwasher on. So certain things trigger us to recall things. Humor does. So when we can do that, we're all going to laugh, and we're going to say, okay, let's remeasure it. You can't have 190 degrees of motion at the ankle. You're looking at the wrong number. And we can look through that. When we measure range of motion, there are a couple of different ranges of motion we'll talk about. So passive range of motion. What is passive range of motion? When I say that, what do you think of?
Maybe somebody assisting you?
Yes, passive is patient's not doing anything or you're not doing it, like you're the patient, right? Patient's doing no work. Best way I can think about that is patient's in a coma. They can't move their limbs. That means you're doing passive range of motion. We are always going to do passive range of motion first, right? Because we want to see what we can get out of the joint before we see what the patient can get out of the joint. It also gives us an idea to eyeball and go, okay, so it looks like they've got about 90 degrees. Now let's have them do it and see what they get. Being able to eyeball angles is really important because it can help you stop from making mistakes. Then we get into AAROM, right? AAROM, are you in the room? AAROM? Some of you will get that. Anthony got it, right? I like you. What does D-Nice? That was my favorite one right there. Yeah, D-Nice, right? What does AAROM mean?
Active assisted range of motion.
Yes, active assisted. Now that can be a bunch of different things. That means the patient's doing some of the work, even if it's only like 5%, but they're doing some of the work, and then something else is helping them move through the rest of it. It could be that they're on pulleys, right? Everyone's seen people doing pulleys at the physical therapy clinic if you did observations, right, for the shoulder motion. When I pull down with my right hand, that's going to pull my left hand up and vice versa. So that's going to help me get through that motion. When you get on an elliptical, really an elliptical is a little bit of an active assist range of motion machine because when you move your arms, it helps move your feet. When you move your feet, it helps move your arms, right? If you let go of the handles of the elliptical and are just moving your feet, those arms still go, right? It's not like they stop. Active assisted there. It's also the reason why when you get on that, you burn a little bit less calories than you would burn on something like a pure treadmill where you're doing all the work, right? Doesn't mean you're not exercising with it. It just means it takes a little bit longer to burn the same amount of calories. Excuse me. Then we get active range of motion. When we get active and say true active, that is the patient doing 100% of the work, right? No help whatsoever. There's no cane, there's no pulley system, you're not touching them. They are doing the work themselves. Do you think that in general, patients-wise, and even yourselves, do you think passive or active range of motion is greater? What do you guys think?
You're saying get farther?
Yeah, which one would go further, passive or active?
Passive.
Say passive.
Exactly. Yeah, right? Even myself, when I get about here, yeah, I can start feeling some tightness in my lats. When I'm actively doing that, my lats are resisting me here, and I can't quite get there. But if I can relax and let somebody else move my shoulder, I know I can get a full 180 degrees. Because passively, it's a little easier. We don't have to do the work. And there's all kinds of things that come into play with that. And then we get the from. What's from? Because from is important. From is probably, out of all of these, I think from is more important than all of them. You guys know what from means?
Functional, maybe?
Yeah, functional range of motion. Good. Because here's the deal. I could have 90 degrees of shoulder flexion, but if I can't reach to my top cupboard to get my food out, I'm not functional. Right? So functional range of motion is really important for us. Because let's say that we have a patient that, for whatever reason, has a bony block, and we're never going to get them to full shoulder range of motion. It's more important to get them to a functional range of motion where they can actively participate in their day than anything. Does that make sense? I mean, it just makes sense to me, is that we want to be functional. We'll talk about functional range of motion for like going up and down stairs with the knee. You know, to walk, you need about 60 degrees of knee flexion. But to go up and down stairs, you need 90 degrees because you have to clear the step. Those are two different functional ranges of motion. But, you know, let's say you were working with me as a patient. I have no steps in my home. I live in a first floor apartment. You know, there's no steps. The biggest step I have is about a curb like that big outside my house. You can teach me to clear that pretty easily, right? So maybe I don't need 90 degrees of knee flexion, right? But then you go, well, what kind of vehicle do you have, Mr. McKeever? I know you want to get back to driving. Well, I've got a Toyota Tundra that's got a 2-inch lift on it. Oh boy. Now I've got to be able to step up into my truck. Now that 60 degrees for walking may not be enough because now I need to be able to get up into the truck, and you know, no one's going to lift me up into my truck. I'm just telling you that. So functional is really important. So this just kind of goes through those. Yeah, I wanted to go through them without looking at the screen. Some of you were probably looking for it, cheaters. But this just kind of talks.
I have a question.
Yes. What's your question?
Sorry, so does the PT or the PTA, do they do this for like the part of evaluation or?
Yeah, so
Okay.
I was actually going to cover that right now. You just led right beautifully into that. Thank you for that. So the patient comes in for their evaluation, right? Which we all know, if you guys have ever seen PTs, they love doing evals. It's the best part of their day. No, they don't. They really don't like evals. I mean, they would much rather treat patients like we do. But eval is their main job. So the patient comes in, and let's say, you know, we're going to talk about this in Therex in a little bit. I came in, I've got a shoulder injury. Well, PT's got to assess my shoulder and see how my range of motion is first, right? So during the eval, the PT is going to measure my passive range of motion. They're going to measure my active range of motion. And then they're going to talk to me about what I do during the day and what do I need to do with that shoulder, right? Let's say that I am a concert pianist, so I play the piano. Maybe full shoulder range of motion isn't as important as maybe getting out to the side as much, right, to play piano. I don't play piano, just to let you know that. But now let's change that. Now I'm a picker and a packer at Amazon. Shoulder range of motion a little bit more important? What do you think? If I'm picking and packing boxes at Amazon, yeah, right? Along with having a bottle to pee in. So all of that comes into play when they're doing that eval. Now the patient comes and sees us because PT evals them, and most of the time in most clinics lately, that's all the PTs get time to do is just evaluations. They rarely get to treat patients. Joe got it. Okay, appreciate it. A little delay there, Joe, but that's okay. Now they come to us and we're going to see them. Well, pretty much at least every visit when I'm seeing a patient, I want to take a range of motion on them because I want to know if anything's improving. So we're going to measure the range of motion and we're going to provide that input back to the PT. Say, hey, you know, Joe today got 5 degrees on his hip. He's been really stretching at home like we've been telling him. Great, the patient's improving, right? So we are going to take the range of motions, they're going to take the range of motions, and then we're going to compare them as the patient progresses. And who else is going to compare them is insurance. Because range of motion is one of the things that insurance use to see if our patients are improving, to validate why they are coming to therapy. You know, in the good old days when I started in the golden age of physical therapy, we didn't have to provide insurance pretty much with anything, and they just paid us. And people have used the system. And, you know, they would see a patient for a total knee replacement for 58 weeks. Even though the patient got better at like week 6, they were still seeing them 50 weeks later. And insurance finally said, hey, you know, let's talk about this a little bit. You're not showing any improvement here, so why is the patient still coming? Or if the patient's fully improved, why are they still coming? Because we like billing, right? So yeah, we will measure range of motion. And again, functional range of motion is not you're not going to measure it so much as watch them do it, right? Going up and down stairs, we can observe if they can go up and down stairs, right? So we'll talk about that as we go through this. End feels. So when we get to an end of a joint, so when I bring my shoulder all the way up here into flexion, and you move me passively, you're going to push me into that little bit of that stretch feel. See what that's called the end feel. So I want everyone to take their hand, put their hand up like this, put their fingers across their fingers and push back. Do you feel that nice stretch going on? If you feel that, that is an end feel, right? So you felt that. Now take your hand and hold it on your wrist and extend your elbow. That's a different feeling because now here, your ligaments and tendons are what's resisting you, right? Because I can pull this and actually if I let go, my hand kind of pops up, right? Because I've got some elasticity in those tendons. But here, that's bone on bone, right? My olecranon is locking into my olecranon fossa. And that's locking me in place. So that's the end feels. The end feel is a feeling experienced by an examiner as a barrier to further range of motion. This will require hands-on experience, and we will talk about the end feels. So there are a couple normal end feels. Normal end feels. Bony. Bony is exactly like it sounds. Bone on bone. Hard, contacting end feel. There is only one bony end feel in the body, and I just told you where it was. Where's that at?
The elbow.
The elbow.
The elbow. That's it. Right? So if you feel a bony end feel anywhere else, that means it's abnormal. Or in the term of Young Frankenstein, if you ever watched that movie, it's abnormal's brain. Right? Abnormal would be if you felt my wrist and you got a bony end feel, that's not normal. Right? But at the elbow, completely normal. Soft. Soft is also known as tissue approximation. So let's say I bend way over into trunk flexion. If I keep bending, eventually I hit a point here where I can't bend anymore. Why can't I bend anymore? What's happening? Yeah, my belly's hitting my thighs, right? My soft tissues are approximating together. Biceps, another great one here, right? Because I got guns. Look at this, look at this, look at this serious gun. No, I don't have any guns, not anymore. But as I bend my elbow up into flexion, right, the meat of my forearm comes in contact with the meat of my bicep. Now, I can actually push it a little bit further. But I eventually get to a point where I can't go any further because the tissue won't let me go any further. Now, say, I'm trying to think who would be a good example of this. Bianca would probably be a good example of this because Bianca's kind of tiny. She may get a different end feel at the elbow. It may not be soft tissue on soft tissue. It may be tension from the triceps, right? And that is a firm end feel. That's what you feel in your wrists, right? I can't get soft tissue on soft tissue here. There's no way. If I can get soft tissue on soft tissue, I've got problems with these tendons. That's a firm infield. That's when the muscle or the tendons are resisting my motion, right? Fingers are another one, right? I can go here, I get soft tissue if I flex my finger. If I extend it, my end feel is firm because it's the actual tendons of my flexor stretching. Does that make you understand the three normal end feels? Does that make sense? Pretty good?
Yes.
So then we go into the abnormals, the AV normals. Abnormal hard. Again, if I bend my wrist and I get a hard end feel, I'm getting bone on bone here. Not good. Maybe one of my carpals slipped and we have to get the PT to put that carpal bone back into place. That sometimes, not that you get an end feel on this, but sometimes happens with the cuboid in the foot, where the cuboid will actually sublux a little bit and drop down. And the PT's got to kind of do a cuboid whip and pop that cuboid back into place. Well, scaphoid, you get a scaphoid whip too, where the scaphoid kind of slides out of place. And sometimes that'll just kind of bang against the bone of the radius and you can't get anywhere. They do a pop. Now I got range motion. But an abnormal hard would be a bone feel that's not supposed to be there. Abnormal soft. Well, let's say I'm doing my wrist here. And I bend down and I get here and I've got a soft kind of spongy feeling that's not firm. Well, maybe my wrist is swollen. I've got edema, right? Or maybe I'm just a big person, right? Some people I've seen where, you know, I can get probably, so if you had to estimate my biceps range of motion. So here I'm straight, right? There's 0. There's 90. What would you say my biceps, or not my biceps, but my elbow flexion range of motion is, estimate?
135.
70?
I heard 135, is that what I heard? Yeah, probably 125, 135, somewhere in that range, right? Now, let's say you're working with a patient and they've got something like lymphedema or they've had breast cancer and that edema pit is starting to fill up with fluid. You may stop here at like 60 degrees because you've got soft tissue on soft tissue approximation. That's an abnormal soft end feel. You may get what's called a boggy end feel. Boggy is a little different than soft. Soft is when things kind of come together. Boggy is when, the best way I can describe it is, if any of you ever sat on a waterbed, right? Or gotten in like one of those bouncy houses, right? Where you kind of, when you step down, things kind of swish around and stuff like that. That's a boggy end feel. It's where fluid, in the case of the bounce house, it's air, right? But in the waterbed, when you sit down on it, it kind of wiggles and forms to your body. That's a boggy end feel. When you get fluid that moves as you're moving them through the range of motion. That's really severe edema. At that point, we've got bigger problems in the range of motion, right? The big problem at that point is the edema more than the range of motion. Abnormal firm. Let's say I'm working with my hand here, right? And you tell me to bend my finger here right at this joint, and I go here and I can't do anything, and then you bend it there and it's firm. The muscle's not letting you go any further. I should be able to go the whole way through there, right? But you're here and it's like bounce, bounce, bounce. That would be an abnormal firm end feel. What do you think would be the cause of an abnormal firm end feel? Where you're getting tightness before you should feel tightness. The muscles need to be what?
Stretched.
Yeah, right? Like right now, if I slide back here and I lean down to touch my toes, yep, I got them. Okay, there we go. I can touch my toe, honestly. But what muscle is restricting me from doing that? Primarily. So I've got my leg straight and I can't see it. My leg is straight on the ground. I'm reaching down to touch my toe.
Hamstring?
The hammies, right? The hammies are tight. And I guarantee when we get kind of doing some labs, almost all of you will have tight hammies, right? It's just, we do. There will be a few of you like Dr. Sokel who can like basically lay her head down flat on the floor between her legs and take a nap. But not all of us can do that, right? Dr. Zokil is abnormally flexible. I will say that. Like, she always shows everyone up when we do. Yeah, she's super yoga flexible. And Dr. Reskin is equally. I'm the person like, I can touch my toes, I'm happy. That's it. That's all I need. I've done yoga once, hated it. Empty Enfield is the main one we will deal with in physical therapy. The empty Enfield is pain. So empty literally means we can't get an Enfield, right? So again, we're working with my bicep here, my elbow, and you're testing my elbow flexion, and you get here, and you can still feel I can go further. There's nothing resisting you. But I'm like, no, stop, ow, 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 that hurts. That's an empty Enfield. Empty means that the patient is stopping you from going any further, despite you feeling that there's further distance. Does that make sense? Okay. So those are your Enfields. So let's say, and we're going to take a step ahead, because we're going to talk about this when we get into actual, because somebody else asked yesterday about SOAP notes. We're going to hit SOAP notes. Don't you worry about that. Let's say we're testing elbow flexion. So what is the abbreviation for flexion? Do you remember?
Flex.
Flex, okay. What's the other one? Check mark.
Yep.
Right? That's the one I primarily use. Again, if I'm writing, you can't really do it if you're typing. Typing, you might as well type elbow flexion, right? So we're doing elbow flexion. We have to indicate what elbow. So we're going to do right elbow flexion. We always start where it starts. So if I'm able to attain full extension, I have 0 degrees. I start at 0. And let's say I can go to 95 degrees. We're going to indicate whether it's passive or active. So say you're testing me passively here. And you would say empty Enfield. Now, let's say I typed that into a note and you followed me the next day. What would that tell you about the patient? Let's just think logically through. What kind of stuff would you pick up from that? Do I have full range of motion, first of all?
No.
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 Right?
They probably experience a lot of pain.
Yeah, and I'm in a lot of pain. Good. That's why notes are important, because that way, you know, when Bianca follows me, she's the last name of the type, so she gets picked on. When she follows me in the clinic, she goes and you see Mr. Johnson here, and she's like, oh, so we're working on his right elbow. He doesn't have full range of motion, and it looks like he's got a lot of pain. Now I have an idea of what I'm going into, right? You know, or if you said this elbow flexion and instead of empty, it said bony. We got some big problems, right? That's not supposed to be that way, right? We may have, there may be some calcification going on, and we'd have to, that's stuff that the PT would eval and we'd have to look further into. But that's kind of what we're going to be doing, looking at with SOAP notes. So here's a couple of different charts on different Enfields. I'm not going to read through them. You guys can read through them if you want. It's just exactly what we just covered.
So, Mr. Akiva, so
Yes.
like, sorry, kind of going back to that, with like
Yeah.
hard, there's really no give to it once you get to that Enfield, but like with abnormal soft or maybe even abnormal like firm, there's still some give to it. Like that's how you could tell kind of like the difference.
Yeah, well, so the main idea here is when you get to those abnormal soft and abnormal firms is, let's say, again, we're dealing with that elbow, right? We know the elbow should have 120 degrees or more of range of motion. We'll talk about the range of motion in a bit, right? But I'm going to use the wrist as a better example because the wrist has about 90-90, okay? How you would know you would either have to put abnormal soft or an abnormal firm is if you got 45. Does that make sense?
Mm-hmm.
At the point you would have to put, because that's not a normal range of motion. But if you get close to 85, that could be a normal firm end feel. just because the person's tight. Does that make sense?
Yeah.
So abnormal would be one that's way off.
Okay.
Abnormal maybe here. You hit abnormal soft, you would put abnormally soft due to edema in right forearm.
Okay.
Does that make
For
sense?
Yeah, it does.
Okay.
And then also like with the functional range of motion.
Yep.
Is there like a standard amount of degrees for, you know, for some of those, like whether it's like knee flexion or?
Oh yeah, and guess what? You're gonna have to know
Okay.
those standards. Yeah, so we'll get there. Don't worry about knowing those all yet. We're like I said, when we go through Therex and Kines, I'm gonna hit the range of the motion manual muscle testing. Therex, we're gonna hit how to improve it. Does that make sense? And we're just gonna keep going down.
Sure. Thank you.
Yep, no problem. That's a great question. All right, do we understand Enfields? Is that okay? Can we move on from that? Because the next one's the fun one. The next one is that arthrokinematics. Arthrokinematics is also known as accessory motion. This is motion of the surface of the joints, right? It may also be called component movement, joint play, joint mobilization, joint manipulation. One thing I want you guys to get out of your head, especially here in Nevada, get rid of that manipulation term. No matter what we do, even a PT does not manipulate the joint. Does anyone know why PTs don't manipulate?
Does a chiropractor moves?
There you go, 100%, exactly. Very good, that's a great guess. I hope that was a guess, maybe you knew. Yeah, because chiropractors say they are manipulators. In order for us to do this, we have to instead change our terminology. So we don't manipulate, we mobilize. Even though a grade 5, which is a thrust mobilization, is the same thing as a manipulation that a chiropractor does. It's all semantics, folks. I'm just going to say that, right? So the only thing I'll say is just ignore this manipulation. In some states, they may use the term manipulation, but that is 100% not okay here in Nevada. Because the chiropractor board here in town is pretty tyrannical about saying manipulations are within their scope of practice, not ours. And it's definitely not in ours anyways at PTA. But I will, like, even when I was in the clinic, I would try to educate my PTs on that, saying, hey, we probably don't want to use manipulation here, just because, right? All right, so our common arthrokinematic motions are roll, spin, and glide or slide. Glide and slide are interchangeable, so if you see those, you can use them kind of interchangeably. A roll is exactly like it sounds. If I'm taking this ball, I'm rolling it, right? Could I also spin this ball? Sure, I can spin it, right? And a glide would be me sliding this stress ball up and down my palm. Does that help make those things make sense? Good, all right. Usually, you're gonna have two motions occurring simultaneously. So you'll have a roll and a slide, or a roll and a spin, or a slide and a spin, okay? When you have a spin, there's an axis, right? It is a rotational movement, not a rolling movement. I like to think if I go back to physics again, I like to think of roll as more of a revolution and a spin as a rotation. If you guys remember back to physics when I talked about this, where revolution is an external axis, where this is internal axis. That's kind of my way of thinking through that, but we'll talk about why that's important in a second here. So don't freak out yet. So here's kind of looking at those, right? So we've got a roll, we've got a spin, we've got a glide. As a ball comes down a hill, it's rolling. Could the ball also slide a little bit as it's going down the hill? Yeah. Right? Let's say you're shooting a basketball and you go for a layup and you shoot it up into the air. one of the things to think about there is the ball is probably going to be rolling, right, when you shoot it, because everyone, when you shoot a basketball, it kind of does this, right? But it's also sliding through or gliding through the air. That's rolling and gliding, right? So convex versus bowling ball is an excellent example. Exactly, yeah. Bowling ball, especially if you put a spin on it, right? Those people that do that just amaze me. So this is the way I remember convex versus concave. So again, I work on Destiny. The little monster that you see up here in this corner, I don't know if any of you play Destiny, but they're the Vex. And this is the way I learned it. A Vex has a rounded surface or a domed surface, whereas a cave is forming a cave, like this nice bear here who's taking a nap down here. Right? So a Vex is an outward curved surface. Cave is forming a cave. Right? So whenever you get a question on the convex concave rule, the first thing you have to figure out is what bone is moving. I want you to beat that into your head when you see questions from me or questions on your board. What I did when I got these questions on my board, I would go, actually, let me erase that. I would write Vex cave because that's what I would always write. So erase. Because I take down, so I'd say Vex cave, got a question on it. Bone moving. And then I would identify the bone that's moving. Because let's think about this for a second. When I stand up, am I extending my knee?
Yes.
Good. But what if I'm sitting here and I'm doing the Rockets and I'm kicking my feet up? Am I still extending my knee?
Yeah.
Yes, right? But there are two different bones moving there, right? When I'm standing up, my femur is moving. When I'm kicking up, what's moving?
Tibia.
Tibia. Good. See, that's the important part. And I think I've got a picture of that coming up here, so I don't want to... Yeah, I have pictures of them coming up here, so good. So when a convex surface is the one that's moving, it will roll in the same direction and glide in the opposite. Okay, so what does that mean? That means if you have a convex bone that is moving anteriorly, it is rolling anteriorly, in what direction is it going to glide?
The opposite.
The opposite, posteriorly. Does everyone kind of see what I'm talking about there? Is anyone not getting that? This is a complex Vex and cave rule here, right? So when I have a convex, a rounded surface that is moving, the bone has a rounded end, and it's moving, it will roll in the same direction it's moving and slide or glide in the opposite. Versus a concave. Now I have a cave surface, and we're going to do an example, so don't totally freak out yet. When a cave surface is moving, it will roll and slide in the same direction. So if I have a cave surface bone that is moving anteriorly, right, it's going to roll anteriorly and slide anteriorly. That's pretty much the way it's going. So let's talk about this here. So here we have a finger, right? And it's really hard to reverse and move the concave surface. So finger's pretty much always going to be that concave surface moving on a convex motion, right? So here's my cave. That's the one that's going to move, right? So we're just going to call this up and down for now. So up is extending, down is flexing, right? So if I am extending my finger, right, my finger, or the phalanx itself, the one that's got the cave surface, would be rolling up So that means it's going to slide up. It's going to be the same versus a vex where it rolls opposite. The shoulder is an excellent example here. So here we've got a shoulder that's moving into abduction. The humeral head is a vex surface. That is the one that's moving, the humerus. The scapula is not really, well, scapula is moving, but it's not moving in the case of this. So as that head moves superiorly, the humeral head has to glide inferiorly in order to keep it in the socket. Because if it didn't, and it actually rolled with the, or if it glided with the roll, right? So it came here and went this way, and it slid that way, it would pop right out of socket. That's what the convex concave rule helps us with. Do I have one of standing up here? Yeah, here we go. All right, so tibia, and the number one question you'll get on your board is convex concave of the knee. The good news is by the time you get to your boards, I will have beat this into you like no tomorrow. And again, don't totally worry about this, because when we get to the knee, we're going to hit this even harder. If the femur is rolling anteriorly, right? What type of surface is the femur? Is it a vex surface or a cave surface?
It's a vex.
That would be a vex.
Right. So if it rolls anteriorly, then which way does it have to glide or slide?
The opposite.
Posteriorly.
Posteriorly, right? And again, if it didn't, if it went together, this femoral head would be out here and be off the tibia, right? And then their tibia problem with it. No? Okay, that wasn't very good. I admit that one, it was bad. Now let's change this a second. So now I've got the tibia moving. So the tibia is rolling anteriorly. If the tibia is rolling anteriorly, what direction is it going to slide or glide?
Anteriorly.
Posteriorly? Oh.
No, remember, tibia is.
So would that be like if you're sitting down, or?
I'm sitting down and I'm doing a rocket.
Okay. Okay.
That makes sense? So the tibia, because it's a cave surface, it moves the same. This is why I want you guys to kind of think about this when you're doing a question on this. Write the bone that is moving. So the question would be, let's put the two different questions down here. So how would these questions look on a board or my test? So one question would say, a patient is standing up from a seated position. With regards to the convex concave rule, the femur is rolling anteriorly. What direction is the glide? And then you're going to go down here and you'll have anterior, posterior, medial, lateral. That would be what a question would look like. So now a patient is standing up from sitting. So the first thing that you're going to do in your head is go, okay, what bone is moving? So what bone is moving if I'm standing up?
Femur.
The femur.
The femur?
Right? I'm going to go femur moving, and then I'm going to go, femur is a cave surface, a concave surface, or convex surface. I'm sorry, I messed that up. Convex surface. So the vex rule is if it rolls one way, it glides the opposite. Yes, right? So then you're going to go, oh, okay, so that means my answer is posterior. Does that make sense for a question like that?
Would they ever ask it like the opposite, or like it'll say it glides?
Yeah, they may. I could change this and say the femur is gliding posteriorly.
Mm-hmm.
What direction is the roll?
For sure.
And again, at that point, you just have to remember femur moving bone, convex surface, opposite. That make sense?
True.
You just go down and
So
pick.
your your convex is always the bone that's moving.
Well, it depends. That's in this case, the convex bone is the one moving.
Okay.
Right, because in this case, it's the femur moving, and the femur has a rounded end. Right. The femur here, down here, has a rounded end. Oh, come on, give me my draw. The femur down here has a rounded end. Now let's change that question real quick. So now we're going to change it, and we're going to say a patient is performing a long arc quad in the seated position. The tibia is rolling anteriorly on the femur. What is the direction of the tibial slide? Okay, so now that's a different question, right? Because now they're no longer, oh God, that's really dark. Can I select that? There we go. There we go, that's better. So now we're changing it because now what bone is moving?
Tibia.
The tibia?
The tibia. What kind of surface is it?
Concave.
Concave. So that means the roll and spin are what?
The
Same.
same.
The same, or the spin and the glide or whatever, they're the same. Does that make sense? That's how you answer these questions. So let's just, do you want to do one more just to see if you can get it?
Can you do one more of that one? I'm sorry.
Just this one here itself?
Yeah, the last one that we just did.
Okay, so
Sorry.
you've got the question here, right? You're going to look at it and go, okay, so the patient is staying stabilized, right? They're kicking up, so that means the tibia is the part moving. Okay, I know the tibia is moving. The tibia has the tibial crest. I'm going to change the color of this real quick, just so that it sticks out a little bit better. The tibial crest is a caved surface. So that means it is a cave moving on a vex surface. That means the roll and glide are the same. Right? So only when you have the vex surface moving on the cave surface are they inverse. So if one's going anteriorly, the other's going posteriorly. If you have them that it's a cave surface moving, they are symmetrical. They're going to move in the same direction. And the way I remembered it, and this may help you guys, is I came up with this a few cohorts ago, is if you have the band one direction, you want to lock them in a cave. What do I mean by that? If you have a cave surface, everything is moving in the same direction. So the roll is going to be the same as the glide. Does that make sense?
Makes sense.
It did. Thank you.
Cool. Do you want to do one more? Or are you okay?
No, I got it. Thank you.
Cool. All right. That's probably the hardest thing. So there's a couple of different, explains the concave surface and convex surface through all those. We'll go into those individually as we go through the different joints. So don't totally freak out yet. Closed packed versus open packed. Do you remember this one? Did you guys talk about this in Intro to Kines?
Yeah, we did briefly.
Briefly, right? Closed packed is the position of stabilization. Open packed is the position of mobilization. When you talk about closed packed, everything is tight. When you talk about open packed, everything is loose. So in the case of the elbow, right? The elbow technically really has has one really closed packed position, and it has another that's mostly closed packed. What do you think the closed packed position of the elbow is?
Extension?
Extension. Yeah, because the olecranon is completely locked into that fossa. You aren't going to mobilize my elbow in that position, right? It's locked in. Technically, full flexion's also pretty well locked in as well, but that is the true closed pack position. Open pack for the position of the elbow is about mid-elbow flexion. Now I can come in here and I can actually distract my radius and ulna from my humerus. So Joe just put Vex, roll, spin, glide.
Can you say like any part of, like, let's say if we're talking about like the elbow, anything outside of like the extension would be open packed?
Yeah, there's a specific degree that is open packed, and we'll talk about what the specific degree is. But yeah,
Okay.
pretty much anything out of extension. I mean, even if you just pop it out of extension, you can mobilize the elbow better,
Okay.
right? So when you want to mobilize the elbow, you have to get it out of closed pack. So I just saw Joe's comment here. So always Vex. Yes, cave is right. It's always the same, and Vex is always opposite. That's a good way of looking at it. I had to read what you were saying there, Joe. Sorry about that. So we'll get into the open packed and closed packed position of all the joints. But the main thing I want you to remember is in order to mobilize the joint, you have to get it out of what?
Closed pack.
Out of closed packed, right? Optimal would be putting it in open packed, right? But at least getting it out of closed packed is better than nothing. So accessory motion forces, we can traction or distract the joints, pulling them apart, right? We can compress the joints. We have a special test for patients with multiple sclerosis we'll talk about, where you push down on the patient's head and you actually bump them on the head. And when you bump them on the head, there's a sign called Lermet's sign. And Lermet's sign will cause their fingers to tingle. It's because of the plaques caused by MS, right? But that is compression, right, or approximation. You're pushing down on my neck, so my neck's squished together. Shear is when two surfaces rub against each other, right? So there's always going to be some shear in our bones, but what helps protect the bones from shearing off each other? What's on the end of the bones?
Cartilage.
Cartilage, yeah, right, articular cartilage. Bending are compressions that go to one direction or another, right? And when you bend a surface, one side becomes concave, one side becomes convex. It has nothing to do with the rule. It's just one side becomes shorter, one side becomes longer. We talked about that in physics. Rotation is twisting motions, right? When I pronate and supinate my forearm, my radius and ulna are rotating around each other. And a lot of times in most places, we do occur multiple forces, right? When we bend over and pick stuff up, we get some bending going on. We got some rotation going on. We'll also have some traction and compression going on. So this is just kind of explaining those forces. And we'll talk more. Again, we're going to hit these more when we get into the specific joints. Let's change to the muscles. Every muscle you should know. You should know the O, the I, the A, the N, and the NR. So the origin, the insertion, the action, the nerve, and the nerve root. Out of all of those, as far as I'm concerned, the nerve root is probably the most important, because that will help you answer most of your neuro questions. And we're going to take a break here in a few minutes. I just got a message. Just relax, guys. Just a few minutes to try to get through this real quick. So when we talk about muscle attachments, the origin is typically the more proximal location, right? And it's usually the more stable position. The insertion is typically the more mobile and the more distal position. Certain muscles can do a reversal of muscle action, where the origin will move towards the insertion. In the case of the biceps, when we take a drink, right, we're doing normal elbow flexion. But if you do a pull-up, you reverse the muscle action of the bicep, and you're actually moving the origin towards the insertion. So there are certain muscles like the biceps and the hip flexors that do have a reversal of muscle action. So do the gastrocs, because the gastrocs can help with, with knee flexion. But when you see something like reversal of muscle action, what it means is instead of the insertion moving to the origin is moving to the insertion. Muscles are named for their location, what they look like, the action they do, the number of heads or divisions they have, the attachments, the origins, the insertions, the direction of the fibers, the size of the muscle, right? What's this muscle up here?
Serratus Anterior.
Good, right? Why is it called serratus anterior?
Serrated.
Moves anteriorly.
It looks like a serrated knife, right? And it's on the anterior surface. What's this muscle here?
Sternocleidomastoid.
Sternocleidomastoid.
Right. Sternocleidomastoid. Right? Cleido is the term for clavicle. So that just talks about how they're named. Why I say that is because sometimes you'll get a question where you will be like, you'll get a question on, I don't know, rhomboids or something like that, and you'll forget where they are. The name will tell you kind of what they do and what they're shaped like and stuff like that. As long as you remember that, you should be good. The fibers, the muscle fibers, if they're parallel, they usually are longer and have greater range of motions. Something like the sartorius, the rectus abdominis, right? The SCM. Fusiform's another parallel. You don't have to know these terms hardcore, but this kind of talks about when you're talking about muscle fiber arrangement, the longer muscles are in a parallel. The shorter muscles typically are oblique, right? But they have a little bit more change the way they pull things. This fun formula down here that I'm sure none of you ever want to know about, the PCSA, is talking about how a pinnate muscle, right, which is what these are, can create force by the shape. This is exactly what you want to remember, right? You don't have to know this. But if you were doing biokinematics, you'd have to know that. So we're not doing biokinematics. I just want to put that on there to scare some of you. Here's different looks at the different fibers. Again, there's not going to be a necessary question on your fibers, but understand that the muscles are named based upon kind of what they look like. So with the muscle, there is a normal resting length, which is just the muscle at rest. There's irritability, how easy the muscle is to contract or respond to a stimulus. There's how much the muscle can contract, the contractibility. There's how much it can extend, the extensibility. And then the elasticity is the ability for it, after it's either stretched or contracted, to return to its resting length. We are going to talk at pretty nauseum about the length-tension relationship in thorax. And this is talking about when a muscle is most active, right? Each muscle in our body has a specific period where it's more active in its motion, right? For example, one of my favorites is squats, right? We've all seen people at squats, and I don't know if you guys have heard this term before, but has anyone heard the term ATF squats or BTF squats? Anyone heard that term before? No one? Okay, ATG, pretty close, Truman. Good. Right? Or BTG if we want to be a little bit more appropriate. It's butt to floor, or yeah, right? I love seeing people do that because, number one, you're destroying your knees. That's beside the point. But the quads themselves have a specific range of motion they're most active. And guess what? That's out of that range of motion. So can you get stuff out of the quads doing those squats? Sure. Right? So if I'm doing a squat, right? A normal squat literally is only about to 90 degrees. But we'll have some people that say, well, the best way you're going to get motion out of that squat is by taking your butt and taking it all the way to the floor and then coming all the way back up. But in reality, what you're doing is putting the muscle in a direction that it doesn't actively fire as well. And you can actually injure the muscle that way. You get more strength training out of not doing an ATF squat or a butt-to-floor squat, believe it or not. But don't tell that to some people, they just won't believe it. And we'll talk more about that when we do the exercises themselves. But that has to do with this length-tension relationship, meaning that, yeah, however far the muscle goes, the longer it gets, right? Actually, the muscle's the other way. Hold on, let me draw that. Oh, I just closed my chat. I don't want to do that. The longer the muscle gets, the less you might get out of that contraction. And we'll talk about specific muscles with that in Therex.
Could you strengthen the muscle like while it's stretched? Does that make sense?
Yeah, you can, but it doesn't. It definitely does not like it. It will not be an ideal strengthening, right? That's why ATF squats are at. Joe just said I tore my labrum doing squats. Yeah, right. Well, that probably didn't help, Joe, right? Having that happen, but on top of it, though, there's just this thing that when that muscle, so when that quad is stretched across all those joints, having that knee fully flexed, it doesn't have an optimal contraction, right? We don't sit on the floor with our knees up in our chest, right? And you guys will know this. Have any of you ever done leg day and then sat on a low toilet? Isn't that the worst? Yeah, right? And then you're like, okay, well, why is that? Well, that's because at that point, the flexion that you have in your hips, your quads can't fire, right? And that's when you're looking for the grab bar. You're hoping you're in the handicap stall to help yourself get up. So we'll talk about the length-tension relationship. But that comes into play with this active and passive insufficiency. We're going to go into this in depth as well, so this is just kind of high level. Active means muscle can't contract anymore. Passive means muscle can't stretch anymore. That's it. That's all it means. Active means, like with the biceps, active insufficiency of the biceps means I can't cause my biceps to curl anymore. Passive insufficiency would be putting the biceps on maximal stretch. So my passive insufficiency of the biceps is when my arm's way back here. Because remember, my bicep crosses multiple joints. The wrist flexors are an easy one because it only crosses one joint here. Active insufficiency of the wrist flexors are when I flex my wrist. Passive insufficiency would be when I do what?
Wrist extension?
Wrist extension, yeah. It's the exact opposite. That's it. That's all there is to it. It's a fancy term for something that confuses a lot of people. So, you know, if I said something like, what would be the passive insufficiency of the ankle dorsiflexors? What position would you put the foot into?
You said passive insufficiency?
Plantar flexion. Yeah, the exact opposite. That's all there is to it. That's it. Right? You're going to put the toes down and do plantar flexion. That stretches out that tibialis anterior. Right? And then it'd be the opposite for the plantar flexors, right? If I need to stretch my plantar flexors out, I'm going to go into dorsiflexion. I know that I'm making that really simple, but it is, and it's a really complex topic that's really simple. I don't know why this one gets people so much. Type of muscle contractions, isometric. Isometric means that same length. There's no movement occurring. Now, caveat, there is sarcomere movement. You don't get what, Brooke? I'm sorry.
The passive and active. I got that one. I messed up on that one when we did intro to kines.
Okay.
It's like not sticking.
Let's go back to that real quick then. That's fine. We'll come back to isokinetic. Hold on there, isometric. Don't you move. See what I'm doing? No. All right, that's some need to laugh. Good. All right. So let's do a couple examples of it. So let's do a hard one, because there is one that I love to do that's really hard. Sternocleidomastoid. Okay? What is the job of the sternocleidomastoid?
Flex and rotate your neck.
Right, so it's flexion to what?
Hyperextension.
Each side.
Flexion to the
The lateral flexion.
lateral flexion, and then is it rotation to or rotation away?
Oh,
Opposite.
Right,
opposite.
good, right? So lateral flexion, same side, rotation, opposite. Does anyone know what this condition is called when I get my neck stuck like this? Babies get it a lot.
Rickets?
Not rickets, no.
Torticollis?
Torticollis, yeah, right? Or otherwise known as Rhineck. Adults can get this too. So don't think it's only the condition of babies. If I'm working on, I've got my monitor over here, and I'm constantly like this working, eventually guess what I end up with? Torticollis. That's why ergonomics is important, right? So this is my motion for my left sternocleidomastoid. Yeah, taco neck, exactly. So if I am in this position, my left sternocleidomastoid is in active or passive insufficiency.
It looks active to me.
Left is active. That means the right would be
Passive.
passive because it's probably on max stretch, right? So that means if I am going to get my left neck, my left sternocleidomastoid into passive insufficiency, what do I have to do?
Turn it the other way.
Turn it the other way, and then what else?
Stretch.
Laterally flex away. Right? So everyone do this for me real quick. Put your head straight up and down, right? We're going to just focus on this one. So lean your head, your ear down to your shoulder, and then rotate to your left. Do you feel that left sternocleidomastoid? I do. Mine's super tight. Oh. Does everyone feel that kind of stretching? Right? When you're doing that stretch, you're putting that muscle into passive insufficiency. Right? So, Brooke, when you're thinking about this, what I want you to think is passive insufficiency equals stretch. Active insufficiency equals contract. Does that make sense?
Like the contract, it would be shortening.
It'd be the shortest it can get, yeah.
Okay.
Right? So you can also think of it as active, short, passive, long.
Is it usually like we're all is it since so like a lot of people or maybe some of us are tight, like let's say with your neck, is it mostly like passive insufficiency than?
Well, there's more things that go along with that, but yeah, I mean, it could be that your muscles are just passively insufficient at this point. So if you have a tight muscle, it is passively insufficient.
Okay.
That makes sense?
Yeah.
Okay, so I've got a USB cable here. I just grabbed one that was connected to my controller. This is, I want to say it's a 4-foot cable. I don't even know. I've got, right? So when I have the cable out like this, what type of insufficiency is it?
Passive.
Passive, right? At this point, the cable is passively insufficient, right? When it's all the way lengthened. Now, if I take it and I ball it up like that, now I've got it to effectively active insufficiency because it's all kind of contracted up, right? I can still, cable's not a really good example of it, but I'm trying to use that as kind of a visual aid. Right, so if this cable could actively contract, out here it's maximally stretched, it's passively insufficient. If it comes together, it can become actively insufficient. Does that help, Brooke?
Yes, so it's active, short contraction, and then passive, lengthen, and stretch.
You got it. That's it.
Okay.
Yeah.
All right.
Right. So let's use the hamstrings as quite a good example. Most of us have passive insufficiency of the hamstrings. right? Most of us are tight in the hamstrings. So we're going to continue to stretch them to make that passive insufficiency a little better. Does that make sense? So that we get a little bit more range of motion, right? In the martial arts, for me, stretching my hamstrings meant I could kick to the head. Whereas when they were really, really tight, I couldn't kick to the head. Which, you know, that's everything everyone wants to do is kick somebody in the head sometimes, right?
What could be an example of this just in the clinic?
Okay.
Like, what kind of questions could be asked?
Well, I try to use the sternocleidomastoid as one, but let's use another one. Let's say upper traps. There's a good example, right? So I come into the clinic, and you see me like this, right? I'm having a problem probably with active insufficiency of my trap here because my muscle's stuck in that position, right? So you're going to have to stretch me out. That'd be one example. Hamstrings are probably the best I can give. So for hamstrings, you come to me, and, you know, I come to you and I say, oh, I'm a diver. There's a good example. So I am a professional diver getting ready to go to states for diving. But man, the diving start position is where you have to stand up and touch your toes and get ready. And I'm having a problem with that. I can't touch the ground, so I can't get in starting position, so I keep getting fouled. So the patient comes to us in physical therapy and says, I don't know why I can't do that. Well, so then we're going to look and go, okay, so what muscle are we having problems with? Where's our problems at? Well, we probably have some problems in the low back with passive insufficiency of the spinal extensors, and probably have problems in the hamstrings with passive insufficiency of them. So we're going to stretch those muscles in order to improve or lengthen them even further. That's kind of what it really means. The knee is an excellent example again here because the knee has two different sets of muscles, right? Here's my ASIS. I've got my rectus that goes there. And then I also have my quadriceps, which goes to the same point, right? My rectus is a two-joint muscle. So in order to get it actively insufficient, I have to think of both the motions. So a question you might get on your test would look something like this. So it'd say, in order, oh wow, you can't even see what I'm typing there. That's not good. Let's change that color. Thought I was going crazy. I couldn't see what I was typing. There we go. In order to put the rectus femoris, I can spell it today, into passive insufficiency, you would need to do what? So we know the muscle we're doing, right? We're doing rectus femoris. How many joints is rectus femoris? Rectus is how many joints?
Two.
Two, right? We got the knee and the hip. So the answers would look something like this. A, flex the knee. B, flex the hip. C, extend the hip. D, flex the knee and extend the hip. So which of those would be your best answer? D, right? Because it's a two-joint muscle, we know that rectus helps with hip flexion and, right? And helps with the extension. So we're going to do the exact opposite. Is that a good example for you guys? I saw Brooke says I feel better about it. Does that give you a nice example to kind of think about it?
Mm-hmm. You lost me where the joint was. I had to think about that.
Okay, let's just do one more since this seems I know this is one that's hard. So let's look, say, instead of rectus femoris, let's say brachialis. In order to put the brachialis on passive, same, flex the elbow. Flex. Somebody driving fast. Okay. So
Sorry.
brachialis is a how many joint muscle?
Just one.
Just one. Yeah, right? What's brachialis's job?
Elbow flexion.
Elbow flexion. That's it. Right? So in order to put a muscle on passive insufficiency, you just do the opposite of whatever it does. So you would put it into elbow extension. Good. C.
Okay.
Do you see why knowing the actions help you out with this type of questions? Because if you know the action, if you reverse it, you put it into passive insufficiency. That's it.
Okay. I get it. This might be stupid questions.
There's no such thing.
But the reason it's just a one joint is because of like the origin insertion of it.
Yep, right? Origin here on the humerus, insertion down here, right?
That makes sense. I need to review that.
Right? But then let's change it a little bit. Now biceps brachii crosses the shoulder, doesn't it? With which head?
Long head.
The
Long head.
tricep?
Good, right? Yeah,
Oh
right.
wow.
Triceps has 3 heads, right? Obviously. So that's kind of the thought process.
Okay.
We'll have more of these, and you'll get a couple practice questions on your test about or your quizzes about this. So don't worry, these will come back to haunt you. All right, so let's get into muscle contractions here. Wow, it's taking a little longer than I expected. How many more slides do I have on this? Does anyone see? Let me see. Where am I at?
I think we're at 48, and
Yeah,
you got
48.
like
We got like 70. Okay,
70.
let's take a break. I think you guys are a little bit fried, so let me pause, or let me stop sharing here and pause the recording. And we're back from break. Let's finish this out quickly. So this one's probably the easiest topic to cover. I think this is probably the one that most of you guys got when I was watching your kinese lectures, the difference between isometric, isotonic, and isokinetic connection or contraction. Isometric is a hold or a no length change. We'll talk about these. A lot of the exercises we'll talk about when you see that are isometric are often called sets. So you have quad sets, you have glute sets, and ham sets, and bicep sets. In this case, sets means no motion, right? So isometric motion, or isometric contraction means the muscle is staying the same length it is. So right now, if I was doing an isometric contraction of the biceps, I would literally just be tightening the biceps, but there's no motion of the biceps, right? I can do an isometric contraction way up here, as long as there's no motion. Isotonic means there is motion. The isotonic consists of the concentric and eccentric motions. I mean, I used to think that the way I used to think is concentric was speeding up and eccentric was slowing down. But now what I think of when I think of eccentric and concentric is concentric typically moves stuff against gravity, where eccentric usually resists gravity. So in the case of something like a squat, when I'm lower, I've got the weights on my shoulder and I'm lowering down, I'm doing an eccentric contraction of the quads. And then when I push and go up against gravity, I'm doing the concentric contraction because the quads are slowing me down and resisting anti-gravity or causing the anti-gravity effect. Biceps are a great idea. And if none of you have ever done an eccentric day or an eccentric week of muscles at the gym, I highly recommend it, because you'll realize how sore you will be afterwards. It is crazy good. Yeah, but you get really you get DOMs really quick from it, right? So like a bicep, eccentric contraction of the bicep or workout of the bicep would be one where I quickly bring that weight up, and then I'm going to slowly lower the weight down as slow as I possibly can, and then return quick, and then slowly lower the weight back down. That slow eccentric contraction really causes burn in those muscles. understand while concentric contractions are important with the human body, eccentric rules our world. If we have problems with eccentric contractions, it's going to cause us all kinds of problems in life, right? Kids have a real problem with eccentric contractions. They haven't developed muscle control yet. And you know this by the way they sit down, right? If I'm standing up and I go to sit down in my chair, I slowly lower myself. Maybe I reach back for the armrest, right? But what's a kid do when they need to sit down in the chair? For those of you that have kids. They do one of these, right? Anyone ever see a kid do this? I don't know what that was. Yeah, they just flop, right? Thank God I got a good chair. So they don't have that eccentric control yet. And guess what happens when we get older to our eccentric control?
Wait.
Go stiff.
It goes down. You know, we lose control, as much of our eccentric control. So therefore, that's why you see old people when they have to sit down, right? Ugh, they've got to use help. And then an isokinetic contraction is one typically in this machine down here that's in the corner. This is an isokinetic machine. These are really cool. They're really expensive too. A lot of times you only see those in work hardening clinics. I do that too. Isokinetic machines are really the only way to truly know how strong your muscles are, right? I always love when I hear, when I go to the gym and I see the true meatheads at the gym, and they're like, yo, bro, what's your 1 rep max? Anyone ever hear anyone ask that before? Oh, so you do a bench, man. What's your 1 rep max? Oh, I have no idea. I don't do 1 rep maxes. That's not real life. Right? When in your life are you ever like, I've got to lift this car off a person? It's not, right? We do stuff repetitively. Right? But this isokinetic machine is really good at determining your 1 rep max. It will push back at you as hard as you push it until you reach an equilibrium where it can't push back anymore and you can't push back anymore. And it will tell exactly how much you're able to force. So that's a lot of use in, like I said, the work hardening or sports rehab clinics. They use that isokinetic machine. You're not going to see that in your average ordinary clinic because this Cybex unit here is probably about, well, this is an older one, obviously with the CRTs, but it's probably $14,000, $15,000. Yeah, Bianca, the one at UNLV is awesome, right? And they just got a whole new set of them. And I'm like, I really want to get over there and kind of play. Maybe I can talk Dr. Telly into letting us go use them. We have some contacts over at UNLV. So concentric, eccentric contractions, I think we've got them. Does everyone understand those at least?
Yes.
Are we good there? Anyone not get that? Brooke, just pick on you.
Now I got it.
I just had to pick on you a little bit. All right, agonist and antagonist. So when I think about this, I think way back in English when we're talking about novels, right? The antagonist of every novel is the person resisting the novel moving forward, right? It's usually the bad guy, right? When you think of like the Marvel Cinematic Universe, the main antagonist in the Marvel Cinematic Universe for the longest time was who? The ultimate antagonist.
Thanos.
Thanos, yeah, right? He was the guy that was stopping the world from moving forward because, you know, snap. The agonists in the Marvel Cinematic Universe would have been the Avengers. They were moving the story forward. See how that, I'm using this as an allegory here a little bit. So the agonist is the muscle that causes the motion. The antagonist is the muscle resisting the motion. So in the case of elbow flexion, what is my agonist?
Bicep.
Biceps, good. And then conversely, my antagonist would be
Tricep.
triceps, the opposite, right? So for knee extension, right, kicking up with the foot, the agonist is my quads. The antagonist would be my hammies. Does that make sense?
Yes.
So if I have a problem with elbow flexion, it could be a couple different problems. It could be my agonist is not strong enough to do it. This goes back to actually John's question just a little bit ago. Goes back to this. It could be that my biceps aren't strong enough to do elbow flexion. It could also be that my triceps are resisting the elbow flexion. Maybe they're too tight. So the antagonist is resisting it. We will hit this heavily with PNF, but it is important to understand the agonist is the mover, the antagonist is the resistor. So let's just say with trunk extension. So if I bend way over here and I extend back, I'm on that back extension machine. What muscles are my agonists for trunk extension?
Quadratus laborum.
Maybe a little bit of QL, good, okay. What's my main ones though?
Or what's that called?
The ones that erect the spine.
Rectus
Spine erectus?
Yes, spinae erector, erector spinae, good, right? That's my agonist. What would be my antagonist then? The ones resisting me going that way?
Your core?
Yeah, my core, my belly, right? Particularly my rectus abdominis, right? Because that's the long strap muscle that's resisting it. Does that make sense for those? Are we okay on those? Agonist and antagonist?
Yes.
Okay, stabilizer or a stabilizer. We had a girl in cohort 5 that she called them the stabilizers, and it just stuck with me because you're stabling the eyes. I don't know. Stabilizers are the muscles that help support the agonist to work efficiently. So in the case of elbow flexion, our prime mover is the biceps, right? But the brachialis is a synergist and a stabilizer. It helps us move through it. A neutralizer would be a muscle that helps prevent unwanted motion. I like to think of coracobrachialis as one of those neutralizers because it helps prevent unwanted movement of the clavicle. And a synergist are muscles that work together. And we'll talk about synergy specifically when we talk about force couples. Closed kinetic chain, open kinetic chain. How are we on those? Was this a tough concept or did you guys get this one?
I always confuse it.
Okay, that's fair. That's why I ask. So closed kinetic chain, meaning the distal end is fixed, the proximal end moves. Open kinetic, the distal end moves, the proximal end is fixed. So let's, in this case, we have the legs, right? We'll talk about the knee. When you stand up, because the feet are locked on the ground, they are fixed. Standing up is a closed kinetic chain activity. Whereas kicking up, because the foot is now moving, that is an open kinetic chain. What about squats? Would they be closed kinetic chain or would they be open kinetic chain?
Closed.
Closed, good. Now, what if instead of the squat, I have you do the hip sled? Does everyone know what the hip sled is? That's where you sit back and you put your feet on the platform and you push out and you push the weight away from you.
Leg press?
The leg press, yeah. Hip sled is what well, okay. In the olden days, we called that a hip sled.
That would be open?
That would be the open, because that's just a squat in a different direction, right? The feet are moving. So the feet are, because they're the distal end and they're the part moving, that would be an open kinetic chain. How about, let's think of a push-up. Closed kinetic or open kinetic?
Close.
Closed. Good. Biceps curl.
Open.
Open, right? How about a triceps push-up?
Closed.
Closed, good. Bench press, good. Open. Do you see how that works together? I had this one once before because there was a question that one of my instructors wrote that was just the most ridiculous question in the world. They have a neck strengthening machine where you put a pad against your head and you do lateral flexion. Would that be open kinetic chain or closed kinetic chain?
Closed.
Think about that for a second. This is the one that gets interesting. Where's the distal end? That'd be the side of my head. So technically, that would be, so doing the night at the Roxbury would technically be an open kinetic chain. If I could move my body, that would be closed kinetic. I don't know why she put that. That was the most mean question in the entire world. I hated her for doing that. That was just a weird one. What about a pull-up?
Closed.
Okay, closed, right? And then what about throwing a baseball?
It's open, right?
That would be open, yeah. So those are some of the things. So most of the stuff we do in life is a combination of both, isn't it? I mean, there's open and closed kinetic that we do all day long. You know, pushing up from the chair might be a closed. Getting something out of the cabinet might be an open. Does that help a little bit, Brooke?
Yes, thank you.
And we're going to go through these for pretty much each joint, so don't totally freak out.
Okay.
Newton's laws. We have three known and then one unestablished law. First law is an object at rest tends to stay at rest, one object in motion tends to stay in motion unless acted upon by an exterior force. You do have to know these for your boards. I'm just telling you. I don't know why, but you do. Law of acceleration. The amount of acceleration depends upon the strength of the force in the object, meaning that you're faster if you have less mass. That's pretty much what it is. Acceleration is inversely proportional to mass. And that makes sense. A tractor trailer truck can't go as fast as a Bugatti, right? Or it can, and then there's lots of problems. Third law is action of reaction, right? For every action, there's an equal and opposite reaction.
Was that the one with the Swiss balls running into each other?
Yep, exactly. Yeah. So, or the, what do you call it? Playing billiards, right? When you hit the cue ball and the cue ball goes, hits and breaks the balls, they all go in opposite directions, but the cue ball still gets pushed backwards, right? And then the fourth law is the law of universal gravitation, meaning that every mass attracts another point of mass by a force acting upon it by the line intersecting path. What that means is that in some way, shape, or form, we are all attracted to each other. That's just the way it is. So if you ever had a bad relationship, don't blame it on the bad relationship. Just blame it on Newton's fourth law. You were just attracted together because you're both objects of mass. Force is a magnitude. Linear force is something acting along the same lines. Parallel force occur in the same plane but not in a line. Concurrent force, two or more forces acting on a common point but push or pull in different directions. And resultant force, the overall effect of two different forces. Whew, that's a lot. There's only one real reason we are going to talk about those. And let me tell you what that is. That is for this effect called the force couple. Right? So although this is all fun stuff, this is the important slide. A force couple occurs when two or more forces act in different directions, resulting in a turning effect. Specifically in the human body, it's with the scapula. Because right now, if you take your left hand and lock down hard on your scapula and do not let it move and try to flex your shoulder, you're going to hit a point where you can't go any further. That's because your humeral head is coming up and banging off the top of the basement of the scapula, right? So in order for you to get full shoulder flexion, the scapula has to upwardly rotate, right? And that was where you get all those fun muscles when you guys were studying, you know, that like the upper trap does, you know, scapular elevation and blah, 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 all those fun terms, downward rotation, upward rotation. The scapula, specifically the rotator cuff and all of the muscles surrounding the scapula form a force couple and allow you to have normal motion of the shoulder. It also allows the shoulder to be a very stable joint despite having many degrees of freedom. So the force couple is what I want you to know out of that. It's multiple muscles working in coordination to form a turning effect. Torque is the ability to rotate around an axis. Now we're getting into basic biomechanics, right? You have to know the difference between the movement arm and the force arm, right? And this is looking at the biceps here. So in the biceps, the line of pull is kind of angular, right? The biceps aren't a straight strap muscle. They kind of form an angle. At 90 degrees, the muscle has the greatest force. So what does that mean? When your arm is really extended, the biceps have to work really hard to get it to 90 degrees. When you get it to 90 degrees, the biceps has a lot of force. That's that length tension relationship we just talked about a little bit ago. So as it moves towards zero, the stabilizing force increases. As it moves towards full flexion, the dislocating force increases. That goes back to that where we have closed packed versus open packed. I know that's a lot. The main thing I want you to talk about when we're thinking about that is that we're going to talk about simple machines and lifting stuff. If I have a patient who I give a 10-pound weight to hold in their hand, it's harder for them to lift that weight than it is to put a cuff weight further up their forearm because I've shortened my movement arm. Center of gravity is the balance point of an object. Where is our center of gravity at? About what level on the spine?
I want to say like T12-ish? No.
Way lower. Did you say T12?
Yeah.
Way lower.
I know it's like belly button region. Is
that's our center? Yeah. So center of gravity is about there, right? And then we have center of gravity here, right? So right about L1, L2, L3 is if you look at the actual human body, right? Okay. Where's our center of mass at, though? That's in our what? Pelvis, right? If you look over here, because that's kind of what keeps us all active. Our base of support is what allows us to have nice, kind of stable process, right? If I'm sitting here and I have 2 feet on the ground and I'm sitting, I have a stable base of support. If I lift my feet up off the ground, I am not as stable anymore, right? Because I've decreased my base of support. If I stand on 1 leg versus 2 legs, I've decreased my base of support. And the line of gravity or the vertical gravity line is the one that passes through our center of gravity or center of mass towards the earth. As we lean side to side, that vertical gravity line is going to change. Right now, as I'm sitting, my vertical gravity line is going to come right down through my body and kind of sit right between my buttocks, right? But if I lean to this side, now my vertical gravity line is coming down through my right cheek more than my left cheek. And my left cheek's up off the chair. And we can use that to help a patient slide forward in bed by having them lean and scoot by moving that vertical gravity line. Levers, oh, these are the fun ones, right? Levers have a force, resistance, and an axis. The first class lever is the most common. That's the seesaw. That's where the axis is between the force and the resistance. When you have that, a longer force arm makes things easier to move because the resistance is short. A shorter force arm requires harder to move, but the force, right? Because you don't have as much range. So in the case of a seesaw, right? If you guys remember back, do they still have seesaws? I don't even know if they do anymore. But back in my day when we had the seesaw, they had these little clunky things you could move in the middle of the seesaw, right? To change the length of either side. So that if I was heavier, right? And the other person was lighter, we could adjust that little clunky thing in the middle and we could still seesaw together and go up and down. Because I was a chunky monkey kid, I'm just saying. I had to adjust that quite frequently. That person needed a longer force arm in order to lift me up than I needed to move them because I had more force to move them because chunky monkey. Your main first class levers happen up in the neck, right? Second class lever, the resistance is in the middle, axis is at one end, and the force is at the other end. The best example of a second class lever in the body is the gastroc, right? Second class lever has a lot of power. The gastroc, and actually, believe it or not, the soleus is probably even a better example of this because the soleus is the strongest muscle by volume in the body, right? So the axis for the gastroc is actually technically down on my feet, right at my toes, where I kind of stand up on my the distal end of my metatarsals, right? That allows me to stand up and come up on my toes. And just think about that for a second. Think of how much force the gastroc actually has to exert in order to get me to go up on my toes, because I'm not a light guy. I'm not going to be able to get the same force by doing something like if you ever had to stand on your hands. It's really hard to kind of push up when you're in that position because your body's not made to do that. We're not made to walk on our hands, folks, contrary to what breakdancers think. Third class lever, the biceps is the best example of that. The force is in the middle with the resistance and axis at opposite ends. This favors power as well, right? It's the most common lever in the human body and allows us to move things around and operate in our own world. So if you ever get a question on your boards that asks you what's the most common lever in the human body, third class is your answer. So sometimes under certain conditions, certain muscles can act as first class lever or second class lever or third class lever. With the biceps, for example, it can change from a second to a third or a third to a second, depending upon what you're doing and whether you're moving eccentrically or concentrically. Are you going to get a question on this on my test? No. But just understand that sometimes when you do an eccentric contraction, the type of lever you're doing actually changes. Pulleys, we have single fixed, single movable, and compound pulleys, allows us to multiply force. We do these a lot with a lot of our exercise machines at the gym, right? Because we can actually do exercises in a smaller area with little bricks of weight rather than having to do, plates and stuff like that all over the place. The Atlas machines are great for that, right? If we add more pulleys to an Atlas machine, we can actually reduce the amount of force required, but we may have to move it further. Again, the gastroc's an excellent example of a pulley system coming around the backside of the tibia, providing that pulley system. Our hands have a bunch of pulley systems in them that allow us to do fine maneuver manipulation, right? They allow us to do this stuff. We must do our exercises. They allow us to do stuff like this. Pulleys improve and multiply force. Our muscles in our hands are really tiny. When you think about them, they're all up here, right? They're all up in this region. But we still can get a lot. I can take this and squeeze it and still get a lot of force in it, despite the fact that my muscles are truly up here, because the pulleys multiply my force. And an incline plane. Ramps are the best example of an incline plane. In the human body, we typically don't have any true incline planes. The best example of that would be teeth or the incisors. But again, we don't really work with teeth except to avoid them in the case of kids. Because just telling you kids will bite you. Just warning you. Any of you that are interested in kids, kids bite. Sometimes old people do too. Just to warn you about that too. Why is the incline plane important? Wheelchair ramps, right? The main thing to remember about wheelchair ramps, because you will get questions on this. For every 1 inch you have to go up, you have to have 1 foot of ramp. So if the steps go up 8 inches, how long does the ramp have to be?
8 feet.
8 feet. Good. And we'll talk about making changes to those ramps later on. This is the main thing with kinesiology we're going to start with. And we're actually going to analyze some people's posture on Monday. Not in here. We're actually going to look at some pictures of people. Don't worry. Not going to look at Anthony's posture, right? We're not going to do that. We wouldn't normally do that in a classroom. Or we're not in a classroom. Posture varies based upon what your position is, whether you're standing or whether you're sitting, whether you're moving or whether that means being dynamic, or whether you're being static and kind of not moving. In the spine, we have 4 anterior posterior curves that serve as shock absorbers and reduce injury. We have the lumbar and cervical curves, which are anteriorly convex and posteriorly concave. And the thoracic and sacral are the reverse. The main thing to think about with this is with front and back curves, those are lordotic or kyphotic curves. Scoliotic curves are curves that we have a curve to the side, and people have what? What's that called? That's called scoliosis, right? So if I have a hump where I'm bent over like this and I look like the Hunchback of Notre Dame, I have typically a kyphotic curve. If instead I'm kind of like this, I have a lordotic curve. We have a lordotic curve down in our low back that helps multiply our force when we're lifting things. Posture itself is going to be assessed by looking through a plumb line. We're going to actually put a line that goes down through the body, and based upon where that line falls, we can tell if a patient has good posture or not. Posture is affected by our anti-gravity muscles, our eccentric muscles that keep us upright. They also affect us with postural sway, leaning forward or leaning back, with the ankle dorsiflexors and plantar flexors. So the posture itself, if we're looking through the lateral aspect of my body, if I'm standing side view for you, and you are looking at my posture, that plumb line, that line that we're going to put down through, should pass through the external auditory meatus, go through the acromion, just in front of the vertebral bodies of the thoracic region, through the vertebral bodies of the lumbar region, be evenly going through the pelvis, meaning cleanly bisects the pelvis, go through the greater trochanter, pass just posterior to the patella, and then anterior to the lateral malleolus. I know that's a lot to remember, but when we do the postural assessment, it will make sense. So we'll need these slides on Monday when we do postural assessment. When we're looking laterally, one of the things that can throw us off is lateral pelvic tilt. That's where one ASIS is higher than the other ASIS. We're going to talk about what causes that in thorax and how we can fix it. When we look anteriorly, if we're going to pass a line right through the middle of me in the front, the head should be extended and level, right? Shoulders should be not elevated or depressed. The line should pass through my nose, through my sternum, right? Pass right through the midline of my pelvis and ending up directly between my feet at the bottom. Feet should be slightly toe out. Hands should be resting at the side in order for a good standing posture. I have really bad standing posture. My shoulders are really internally rotated, and that affects my overall function. Anterior and posterior pelvic tilt. We will cover this in depth when we talk about the lumbar spine. But anterior pelvic tilt is where ASISs are pointed down and your high beams are on. Posterior pelvic tilt is when your ASISs are pointed up and your low beams are on. We'll talk about this looking at the drawer. Sometimes we call anterior pelvic tilt open drawer and posterior pelvic tilt closed drawer. But if you put your hands on your hips right now, and you allow your pelvis to rock upward, right? That's a posterior pelvic tilt. You allow it to rock forward. That's an anterior pelvic tilt, and my back just popped. Neutral tilts where we want them, where the ASIS and PSIS are level as possible. There, we'll talk about this in depth when we talk about the different muscles, but this is another form of that force couple where the muscles work together to move the pelvis. And then from the back side, the main thing here is same as the front. The line should pass right through kind of my butt cheeks, right down that posterior cleft. The knees themselves should be nice and apart. No valgus or varus. We'll talk about valgus and varus in this class. And the calcaneus should be fairly straight. Posture itself, the main thing with this is the more that we slump, the more we increase pressure on our vertebral discs, right? When we talk about ergonomics in the workplace, the patient should have their feet on the floor and their back should be upright. I really like my chair because my chair has an active lumbar support that forces me into a lordotic curve on my spine, which actually just sitting in it upright, it feels a lot better than the way I normally sit like this, right? When I'm playing video games. Everybody should be in alignment. If I can sit upright like this, the pressure on my discs instead of being 36 pounds is now 12 pounds. And that's pretty significant. That's a pretty significant drop. Supine posture, we've covered this ad nauseum. Supine's laying on the back. It's considered the most comfortable resting posture, but for some of us, we'd argue that. I hate laying on my back, right? The heavier you are, typically less you like laying on your back because it puts compression on your core. It's a good supportive surface is important in order to not wake up with back pain when you're laying supine. And man, I just realized that picture looks really inappropriate. We're going to move on. Sideline posture is a lot of patients will prefer this, where either the bottom leg is extended and the top leg is flexed, or the pillow is between the knees to keep them sidelined. Prone posture, not recommended because of the stress it puts on the neck, but there are positions to put them in prone. And we also realized down in the right corner that prone was a good position to fight COVID because it puts the bronchioles in a position where the drainage actually goes out of the lungs. For patients that died from COVID, they died a horrible death. They literally drowned in their own fluids. So COVID was no joke. This is a surgical posture. This was kind of the posture they put me in when they did my posterior cervical fusion. This was not a comfortable posture, and I still actually have bruises from being in this posture for like 13 hours for the surgery. And this is looking at the disc pressure. I know he covered this last semester, but looking at this, just look at how much posture affects our discs, right? When we're laying supine, we only have about 25 pounds of pressure on it. If we just lay sideline, we triple that pressure. Standing up quadruples the pressure. Standing up, leaning forward, oh God, that's 6 times the pressure. Now we add weight. Look how much that does. Just adding, and I want to say that was 20-pound weight is what they added in that picture. So adding 20 pounds increases the pressure on our disc to 220 pounds, or PSI, pounds per square inch. Seated is 140, leaning forward is 185, leaning forward weight is 275. So that leads me to think about when you're doing stuff like curls and that at the gym. If you're just doing curls in the air, are you putting a lot of pressure on your spine?
Yeah.
Yeah, right? And I've had patients that are gym guys that go to the gym all the time. Like every time I do curls at the gym, my back starts hurting. Well, that's because you're increasing the pressure so much, especially considering the posture you see people doing curls at, right? They're bent forward doing it. Now you put their arms over a preacher bench and have them do curls, and all of a sudden they say, hey, my back doesn't hurt as much. Well, it's because you just disperse the force across the back of the arms a little bit. So think about your posture, folks, is all I'm saying. How many of you guys right now are willing to admit you have bad posture sitting here watching this? Using staggered stance does help a little bit. Yeah, Brooke's like, yeah, right? You guys are watching me, and as I sit here teaching, I'm like, starting to fall forward. All right, that is it for that kinesis lecture. That was longer than I thought, but we covered some important things that seem to be kind of tied up. Do you guys feel better about stuff like eccentric, concentric, the roll, spin, glide, stuff like that? See Jason nodding his head a little bit. We will, trust me, this whole semester, it's not going away, folks. It's going to come back to bite you the whole semester. Oscar's smiling face there is telling me everything. All right, let me close that one down, bring up the Therex. The good news is we're going to finish the first Therex lecture and start the second one, and then probably get out a little early today because I know it's your first week. I don't want to totally burn you out the first week. I want to wait till I get to the second week to burn you out. All right, share screen.